All right. Hope everyone had a good lunch hour, good discussion going on. So I'm going to introduce our afternoon keynote speaker, our CEO and President of UTMB Health, Dr. Reiser. To say a few words about Dr. Reiser, I think his presence at this event and his provision of the keynote is sort of an emblem of the fact that he cares about AI a lot. It's been a big part of his vision, a big part of our strategy because of his vision. And he comes to us with deep insight, not just in medicine, AI, entrepreneurship, and how these fuse together to really bring us to tomorrow. So I'm excited to introduce him to come and share some insightful thoughts about where we are now and where we're going. And thank you, everyone, for your time and attention. Thank you, Dr. Reiser.
Well, thank you, Peter. Thanks everyone for coming here. I was 2 years ago, shortly before I went to UTMB, I had a chance to look at the new building and I thought to myself, how would it be to actually be in here with a lot of people on a symposium? So today I was asked to give my thoughts on AI, and then I realized I'm a molecular biologist and I study molecular kidney disease, and what do I really have to do with AI? But luckily, the UT system is so collaborative and so powerful that I had so many interactions already with many of you in the room, Dr. Zervas, Dr. McCaffrey, and so many others, that I had a little time to think about AI in the greater scale. So this morning, a friend of mine from medical school, he is now the head of Pfizer Germany, and he said, don't mention my name. His name is Dr. Christian Lenz. I'll mention him. He loves AI. He sends me a joke and says a husband asks his wife, why are you whispering in the house? And she says, looks at him, well, I think Google is listening. And he's laughing, and then she's laughing, and Alexa is laughing, and Siri is laughing, and the Tesla is laughing outside. So I'm like, this is a good joke. I'm gonna tell you this. And the other part that I want to share with you is, I grew up in the Black Forest. I keep saying this, but when I was 15, I had a little motorbike, and it's only allowed to go 15 miles per hour in Germany, so we all modify it. And I got caught by the police, and they sent me to 4 hours of community service at the Red Cross. And I'm like, okay, that's good. Red Cross, we can do something good. At that time, I was terribly scared of dogs. And people who know me today, I love dogs. In fact, I have so many in Germany and here. And so I go to the Red Cross to start my community service, and they didn't know that I was coming, and they had nothing to do for me, and they said, why don't you just take the 3 community dogs and walk them for 4 hours? I was terrified, right? That was the perfect punishment for me. But what happened is I survived the 3 dogs over the 4 hours, and I became a dog lover. A little bit it's like that with AI, right? The more we are exposed to it, the more we are thinking about it, the more we get comfortable with it, the more we see its use and we get fascinated by it, and we see how much AI is really touching so many areas of academic medicine, healthcare, education, and research. And with that, there's a full circle back to being a physician scientist. So, now after this long introduction, a little video.
Artificial intelligence is advancing rapidly. And with it, the opportunity to transform how we deliver, understand, and improve healthcare. Across the University of Texas system, we bring scale, scientific depth, and a commitment to responsible innovation. Together, we can accelerate the adoption of AI that is ethical, evidence-based, and impactful. This is our moment to lead. The University of Texas system.
I think that's going to be the main punchline of my talk today, trying to talk about unity and collaboration across this massive scale of what we call UT System, and also invite other partners, such as we heard this morning from Vanderbilt, and their systems to participate in really a revolution of AI. Because if anything, AI is not overhyped, it's probably underhyped, and it's certainly here to stay, and we got to start working together to implement it. So as you can see here, scientifically, I have been dealing with 3 particular areas of AI. One is AlphaFold 3, which implies immediately there's an AlphaFold 1 and 2. AlphaFold is there to determine protein-protein interaction. And I like to show this because I trained so hard in medical school on doing Western blotting and protein-protein biochemistry, immunoprecipitation, and now with AlphaFold 3, we are at a level where AlphaFold 3 is probably better than the best performed Western blot and IP to determine protein-protein interaction that we can do. And it's just incredible. The other part is EVO2, which is a truly generalist biological foundation model, which can determine whether a mutation is meaningful for disease or whether it is something that is sort of like just part of perhaps evolution, but is not directly related to a disease. It's based on 9.3 trillion DNA base pairs. It's hard to imagine that number and the capability of this model. And DiffDoc is another model that is developed to understand functional biology, where we look at receptor-ligand interactions just in a very different way. So think of it as knowing the structure of a receptor and a ligand. You can model with a human mind how they might interact, but this model is actually able to take information in a way that it has viewpoints and view angles that a human mind simply is unable of doing. So those are 3 transformational scientific developments that we use as scientists, and I use on a fairly routine basis. Just on Saturday, after this meeting, if you have time to go to the West Coast, there's the American Thoracic Society will be discussing interim data on a new drug called rentosertib. Rentosertib and In Silico Medicine is the company. They were the first to use a complete algorithm-designed drug development pathway. In short, rentosertib was designed via In Silico's pharma AI platform using AI throughput by identifying a novel profibrotic kinase target, TNIC, using the PandaOmics multi-omics engine. Then they generated lead molecules using Chemistry 42. They filtered candidates, did PK/PD studies with an in-clinical module, and they synthesized profiled top AI designed in-clinical drug candidates. And that all happened in 12 to 18 months. Now, I happen to be an entrepreneur in my life too. I'm part of a pharmaceutical company in Cambridge, Boston. We started a company in 2012. We're 13 years later, and we are just now running phase 2 clinical trials. This development did it in 12 to 18 months. And I see Dr. Gupta in the audience. He's the director of our innovation platform at UTMB, and he loves stuff like that because this makes it doable at a university setting. 12 to 18 months to get to this level is possible compared to 10 to 15 years, which is really not possible at a university. And on Saturday at the West Coast, I believe the meeting is in San Diego, the results of the phase 2 trial will be unblinded to some degree, and the whole world is actually looking forward to it. So if you have a chance and you remember the name, it's worth looking up and see what it's doing. And it's for pulmonary fibrosis, and as you know, it's a pretty devastating disease condition that often leads to death within 3 to 5 years. So we're excited about something like that. Now, if you look at these developments like AlphaFold, EVO2, and DiffDoc, and rentosertib, you can see that this is not just better. This is not a stronger engine of some sort. This is really not just simply replacing human tasks, it's uncovering entirely new paths to knowledge. AI models leverage unique cognitive strategies that humans are just not very capable in doing. We have other capabilities, and we should continue to focus on those. We need to continue to remind ourselves what it is to be human, especially in the healthcare and the educational sector. But when it comes to these sheer computing tasks, and these systems just have a higher capability than we do. And this evolution also redefines how we approach complex clinical challenges, pushing boundaries from assisting human experts to augmenting and even transforming the clinical thought process itself. Now, here's another example of diagnostic and conversational AI. This is the Articulate Medical Intelligence Explorer, AMIE. AMIE was developed by, I think, by Google and Stanford together. And so AMIE is a large language model that can switch between being a patient and being a provider. And so we are doing this today in the educational sector, where we tell our students, you should be a doctor, and the next task you're going to be the patient. And this is how we learn, because I would argue, and you would agree, it plays a big difference whether you're at the receiving or giving end of a diagnosis. So AMIE does that. And then when AMIE was tested against top providers, it was just simply better in accuracy of finding the diagnosis, but also in putting relevant differential diagnosis on the map as well. So here's a little system demonstration how AMIE really works. So it's really good in history taking. It's probably not going to talk so much about the baseball game last week, but it's a little bit more focused. It does this really well. Make sure that everything is protocoled and stored properly. And then it delivers a diagnosis and a management plan, answers follow-up questions, just like a doctor. And finally, formulates a treatment plan. And when this is run against human providers, it pretty much outperforms physicians. Now, the other part that's so fascinating about AI, and we've heard about it this morning, is that the scaling laws are continued to expand. So there's different type of scaling laws, and it goes quickly into computing, which we don't want to do this afternoon, but essentially there is no limit yet that we see when it comes to artificial intelligence. It's just getting smarter, and the IQ is continued to rise. And I don't think it's an overstatement to expect that IQ of AI, which is currently probably, about 140, 150, might be able to be at 300, 500, or it's a different type of intelligence. So the question is not whether AI will grow, but the question is how will we grow with it, and how do we do this? Also, on the lower part of the graph, you see hallucination. Hallucination means that an AI got something wrong. Even that can be managed. There's, for example, the O1 or the Gemini, which, as you can see, there's less repetition, less memory, but more thinking before it goes to the next step as part of the algorithm. And when one does that, it essentially does not create any errors anymore. And so there are some systems that are very good in performing simple tasks like coding or orienting data, but there are some others that involve critical thinking up front, and by doing that, they might be not as efficient in categorizing data, but they certainly avoid error. And so right now, as it stands today, we really haven't reached a ceiling yet of AI capability. And I think this is fascinating, perhaps a little bit scary, but it's really a call for all of us to come together and harness and oversee these technologies together. So now we come to the why Texas, why now? I think one part is that only in Texas you have the weekend playing music before you give a keynote. I think this was already really cool. If I had any type of nervousness, it was immediately gone. there is something special going on in this state, and I think this is the sheer will to come together and make things happen. And this is not just the size, it is really how everyone here is engaged today and in general. We want to solve problem. And when you look at our map, which always reminds me it's about twice the size of Germany, we are home to a huge land. We have 30 million people. We have both urban and rural areas. We have a lot of diversity. Look in this room. We have diversities in our community. We at Galveston at UTMB. I always say if we cut off the causeway, we have another Framingham study, essentially, with the 65,000 Galvestonians. So the state of Texas is ideally suited to harness the impact of AI and study AI. And if we succeed here, responsibly, equitably, and at scale, we can inspire the world. So I heard this before this morning. At UT, the sum is larger than the individual parts. We got to remind ourselves, this is the time to reach out to your colleagues at other UTs and outside universities and come together, develop cross-institutional ideas, tools, study outcomes together, and learning, and be clear to each other what it is that we are trying to accomplish. Because shared tools really here means shared talents and finally also shared success. Now, we have an extraordinary amount of disease burden in the state of Texas, and perhaps even more so than some other states when it comes to, let's say, diabetes, for example, and kidney disease. There is 3 million people with kidney disease. We have a very large number of people with debilitating neurodegenerative diseases such as Alzheimer's, for example. We had recent legislator approving a $3 billion DPRIT. Thanks to the lieutenant governor, we have now the opportunity within Texas that no other state has to come together and study how to tackle dementia and Alzheimer's disease. And why not doing this also through the power of AI? But Texas, in this regard, we cannot afford to go forward the way we are thinking about our state and the economic growth that is happening in the state without not attending to this opportunity that is in front of us, which is to harness and study AI together and collaboratively. Just as a quick reminder, the University of Texas system is multiple institutions, 14. Here you see the health-related institutions. There's a reason why UTMB Health is at the left top. We are the oldest institution. We're also very good. I don't want to say the best. I think so, but I'm biased. It's really remarkable what each institution have. For example, looking at UT San Antonio, which has a medical college now in combination with AI. It's one of the first colleges that I can remember that is educating medicine together with artificial intelligence in silico and providing a curriculum that really educates the next generations of physicians. It's exciting. So if we look at our partner institution, we heard a strong demonstration this morning of MD Anderson, for example. If we look together and work together, the sky is really the limit. So what are our current realities, our promises, and what are our pitfalls? Well, so when you look at human versus AI mammogram screening, so we can see that there are not that many differences yet. We have opportunities when it comes to screening, for example. There's a lot of tiny little pixel changes on images that can be picked up by a computer algorithm or by a large language model that the human eye is simply not able in identifying timely. And that saves lives. So I think that's a huge opportunity for UT system to look at screening in general and mild or early disease. It's so easy to miss that. When we look at AI-powered incidental coronary artery calcium scoring, I see our cardiologist, Dr. Hani Chinet, sitting here. He's the director of a new Sealy Heart and Vascular Institute at UTMB that we just recently opened. He's really a champion in coronary calcium. And not to over-disclose, but I myself got a coronary calcium score 4 years ago, and since then I'm on statins. And it has changed my life, quite frankly, because I think I was not on the best path going forward, but luckily I was able to get this voluntary test, and that has helped me so much, I hope, and also changed my life quite a bit. So we want to harness those opportunities for our patients, and we want to make sure that we don't do one-offs, just like the stories we heard this morning from Vanderbilt. We want to hardwire those opportunities that medicine has by harnessing AI. There's AI-assisted ECG interpretation. By doing that, we can miss errors and reduce all-cause mortality post-discharge for monitored patient. So very exciting. And AI-assisted endoscopy, another area. So those are just 4 examples. There are many others where AI is driving meaningful outcomes and meaningful change. So, but we also need to come together to build a stronger, clearer understanding of where AI works and where it doesn't. Like, for example, when you look at the large system of Kaiser Permanente, data from over 2.5 million encounters and over 7,000 providers shows that ambient AI saving, so AI that records patient-physician encounters, saves around 1 to 2 minutes of time per node on average, but it's highly variable between providers. And I remember myself when we introduced Epic at the time when I was a resident and an attending in Boston. It took me just longer to get used to Epic. I dread it. And others were very faceted. And the way to overcome is that we have to break down the barrier. We have to provide education, teaching, and access and help at universities to make sure that providers will use the technologies. Ambient AI sounds great, but for some providers, as shown by some studies, this has increased physician burden because it doesn't feel so natural for the provider to be using that tool, because some people are stronger and enjoy more the patient interaction than others, and some find this of hindrance. And so we need to continue to invest resources. We are doing that at UTMB, I think, and I think after these meetings I will be asked to invest more, and we will, to make sure that these technologies can be trialed and can be utilized. Successful AI is deeply dependent on workflow, clinical buy-in, and mutual understanding, and this continues to be an area we have to reinforce and invest in. We also need to come together to make sure that our IT systems, I see our IT folks here in the audience, feel supported, have the support that they need to make sure that the workflow can be rigorously updated and we can work with this new technology and not feel barriers and have to overcome issues all the time. So, close to my end, I want to reiterate why I think I'm here today. I'm excited as a physician scientist. I hope this comes through by sharing a little bit of my personal story. But we have a strategic value that's massive, and we can really take on AI in literally every aspect of academic life and the healthcare system within the University of Texas system and our own institution. We can improve services, streamline tasks like scheduling, appointment, requesting refills, using telemedicine more easily and efficiently. We can restore the human connection and make sure that physicians, nurses, and providers who came to healthcare because of the interaction with people can really do that, and we can reduce the clerical burden that is typically generated by so much documentation, by having large language model help us with that. I see many of our partners here in the audience from industry and technology who are doing just that with us. We can unlock new capabilities like gene therapies, drug discovery, and augmented reality surgical planning. An example is the drug that's was generated just recently in 12 to 18 months. We can do now a good deal of drug discovery, drug development, device development within our own academic institutions and provide students a unique resource of education and experience. And we can perform personalized care, enable more active disease screening, earlier screening, better diagnosis, and earlier change of life therapies that really make a difference. So we want to enhance the human experience in healthcare, not replace it. I think this is very important, and we need to reiterate that. We want to focus on access, quality, and responsiveness, particularly in underserved and remote regions. And if I go back for a moment, we have quite a lot of areas within Texas that are underserved, that we otherwise can really not reach very well. So now, as I close, when I came to UTMB, which is now almost 2 years ago, I was surprised, positively surprised, that UTMB had already more initiatives than any other place that I've seen, including the past 2 universities that I have had time to serve in. One is ambient dictation. We're doing this. My doctor is in the audience as well. He uses ambient dictation on me. I enjoy it, and it seems to be working well, and that is something that UTMB is doing already for quite some time. We have responsive patient messaging. We're using AI to triage and accelerate patient communication. We have personalized risk screening, proactive identification of at-risk patients across cardiology, nephrology, and other areas. We also have generative AI access across enterprise and make sure that tools are being made available to our learners and our physicians across our entire health system of UTMB, because we have by now 6 hospitals across various regions. When we talk about AI, we need to talk about ethical AI. We have heard a little bit about it today. Terms like governance, scale, pilot, and vision has to be center. We have to focus on thoughtful governance, pilot evaluation, and human oversight. So as exciting as it is, we have to make sure that we are advancing AI technologies safe and also with appropriate caution. Our responsibility also means a commitment to understand and master these tools, something we can only do exactly that through a culture of exposure and experimentation, not of avoidance. Again, this is where partnerships and collaborations between various UT really is helpful. And on the educational side, we have a brand new health education center. It's a virtual hospital and educational facility. It's one of the largest in the United States. And we have AI tools employed today where we deliver a personalized level of education so students can go back to their areas where they particularly need help and here in different variations and different forms, educational elements that help them to understand the very complex landscape of medicine and science. And we're also educating our teachers in there because they're part of the educational workflow and process. Just like the model that Stanford and Google developed, the AMIE model, our teachers and our students, they change roles when it comes to education as well. I think there's a very, very big role for AI in educating our healthcare workforce tomorrow. For us, that's very important because we are educating up to 20% of all physicians in the state of Texas, and for us to stay relevant, we simply cannot turn a blind eye to AI educational opportunities. AI also helps enrich the training experience in general, enabling students to become more capable professionals. And this is in some of our simulation experiments or educational modules that we provide, we focus specifically on empathy content. We are bringing in another company from the East Coast that focus on providing empathy feedback to nurses, to students, and also within our schools. This will be a pilot that we're engaging with, but there's so much opportunity in making the human touch, the human connection more human through AI. I think this is a real opportunity. As the machines get better on the tasks that have really not a lot of emotional component, we can utilize the machines to help us to become more caring humans to other students within our ecosystem of the university and within the healthcare system. And finally, I want to point out a couple of partnerships that we have across the system. One is the UT-HIP AI Collaborative. So UT-HIP means Health Informations Platform. I'm serving on this council, and it's something that Dr. Servers and Zane and the UT system put into place. It's a cross-campus effort to guide responsible deployment and share best practices. Our colleagues at Southwestern have been leading the space with a trustworthy, responsible AI network called TRAIN and the Coalition for Health AI, CHAI. So I think that's another shout out to them for being key partners for a long time in this part of harnessing AI capabilities. And we're also partnering with startups. I already mentioned San Antonio as a particular strong example where UT San Antonio is using the capabilities of AI in a more stronger way. Yesterday, we announced the opening of an artificial intelligence center at UTMB under the directorship of Dr. McCaffrey. And we want to sort of like follow the track of activities that are at UT San Antonio. So we're learning from each other, which is really good. So the other part is why we need collaboration. We need to co-evolve with AI. If you look on the x-axis, the collaborative implementation is really absolutely key to the transformational potential. We are trying to bring an enormous amount of new knowledge and technology into a university. And the only way we can do it in a reasonable amount of time and with success is by collaborating together and use the scale we have. And in so doing, we need not only to support our workflows, but we need to change them and challenge them. The value, utility, and reliability of AI in healthcare and real healthcare is subject to a new scaling law defined by our implementation and the rigor with which we test and track real processes with this tool. So we can make AI better and better and better. If we don't do our scaling law and our part, we won't be able to harness it. It's that simple. So I think that's a really important message of my talk today, and I hope you'll take it home with you. So conclusion is, let us be the system that wrote the playbook on how to do this right. I had another video, but then I'm showing too many UTMB videos. So no more UTMB video at the end of the talk, but a pleasure to be here. I think we have 10 minutes or so for some questions, and I'll try to answer them. Thank you.